Similar again to Peter will be based on things we know from Fragile X syndrome, which is a condition which is probably, of the monogenic conditions, it's probably the one which is one of the most advanced in terms of these sort of trials, attempts at trials. I always have to do expectation management. Fragile X syndrome is one of the most advanced. There are yet to be any successful trials coming out, and we can talk about some of the reasons. Peter alluded to some of them right there. We need to get right a lot of things to make trials happen and to make them happen well. So what do we need to know? I mean, this sounds pretty obvious. What medicine might be helpful? That's really the first thing. Who should we give it to? How long do we test it? What do we measure? And how do we get enough people to take part? I'm going to touch on each of these and talk about some of the work that's gone on, looking at sort of the possibilities and things for each of these. Again, like Peter and like everyone else today, which is it's really nice. I'm quite happy to be interrupted for questions at any point. I don't need to go into this in any detail at all because, again, it's already been discussed. Understanding how biologically the proteins that are coded for by the SYNGAP1 gene, where they fit in the synapse. This is two nerve cells basically talking to each other. And SYNGAP, understanding these pathways is key to understanding what the gene does and how we might do treatments. And that's where the laboratory science stuff comes in, and that's why we spend so much time working and talking about these things with each other. And you've seen this data already. When we think about what might help, this is a paper from 2015 by Stephanie Barnes, what Peter presented. I've just focused on the lovastatin here. They did try a few things, but as you can see, lovastatin helped in these two biochemical, we call them biochemical phenotypes or biochemical pathways. So in this mouse, with this kind of SYNGAP knockout, lovastatin was helpful on these measures. Okay. And as Peter said, statins are super common. I mean, loads of people, there'll be people in this audience who will be on statins. I think you can buy simvastatin over the counter pretty much now. So they're super common medicines, which is good for lovastatin because it's widely used in the US, in parts of Europe. In the UK, it's not actually licensed for use. That means that as a doctor in the UK, I can't just write a prescription for lovastatin and have it easily prescribed. There's no particular reason for that other than that it was just never marketed in the UK. So it's not that it was rejected or that there was problems with it, it's just not used. It does make doing trials of lovastatin more complicated from a kind of approvals point of view. Getting the regulatory authorities to okay us to do trials with lovastatin are more complicated than they would be if it was one of the other statins. But there are a couple of papers, and some of you will have seen these, that have been coming out. They're not, as Mick said earlier on, they're not papers, they're letters. They're single case studies in people, both adults, with SYNGAP1. This is the one with lovastatin that has just come out this year. Looking at one person and looking at treatment with lovastatin on a few different behavioural measures. So they looked at a thing called the ABC, Aberrant Behaviour Checklist, Repetitive Behaviour Scale, Social Responsiveness Scale. So this is general behaviour. These are kind of autistic-like traits. And what they show are some improvements. It's slightly unusual. It's done over about 2 years, but for about 15 months, the person wasn't on the lovastatin. They went up to 20 milligrams, then they went to 40 milligrams of lova. Then they thought maybe it was causing some problems, so they just stopped it for a year and a half. And then they thought, we'll try it again at this sort of 19-month time. And they showed some improvements. They showed quite dramatic improvements, which is, yes?
I was just going to say, those measures are exactly the ones that I was talking about in the behavioural phenotyping talk. Particularly the SRS2 is the one we'd use to measure the autistic presentation together with the RVS. So that's it links in with that straight away. Yeah, they're quite dramatic falls in some of these measures. And this is an adult person. This is someone who's 30-something years old. So it looks positive. Okay.
This is another letter, recent one, rosuvastatin, in a patient, I think they were 19 years old. This was done in Germany, I think. And they give 3 months treatment, and they report what they describe as improvement. They say that prior to it, they had 100 episodes of epileptic discharge and 4 myoclonic seizures in a 24-hour period. And after it, they had 90 episodes of epileptic discharges and 2 myoclonic seizures, and it was a bit better. Now, this, pardon? No, I mean, this to me is that, and they measured these discharges using, they were using EEG. This wasn't, the person wasn't having 100 seizures a day. This was just measured using the EEG. You know, these are less impressive improvements, I would say, than in that lovastatin case. You know, I mean, this could just be fluctuation, etc. I'd like to say, do some expectation management. I caution a lot about this, because we've done, so far, there's been one published animal study. Now, it's the one that was done in Edinburgh, in Peter's lab, Steph Barnes, it's been done in mice. It looked at these limited measures, these biochemical measures, and it tested lovastatin. So it has maybe some relevance to that first patient study, you know, first case report that was done. Doesn't have relevance particularly for that rosuvastatin thing, because we know that, again, work that Emily Oswald's done here in Edinburgh, that in our Fragile X mouse model, lovastatin seems to work, but simvastatin doesn't. Now that's important for us in the UK, because simvastatin is dead easy to get, but and rosuvastatin is too, actually, but she's not tested it, but we think that we will probably have to go for lovastatin rather than trying something that's
That's just a silly question. You mentioned statins are very, very common, and they are obviously. So lovastatin, is there a particularly bad side effect to it?
Yeah, why is it not available in the UK?
So it's not available in the UK because it was never submitted for approval here. It's a marketing thing, rather than it wasn't rejected from approval in the UK. Yeah.
So my question would be, if there's not a massive side effect, and I'm sure it's a great reason, what would be to stop you, you've said, so having a go?
Just having a trial of a statin. And there are people out there who would be. So I can see Peter raising his hand at the back.
So in the Fragile X, a lot of kids in Fragile X went on it, and they came off it quickly because it has acute effects that are negative, and what they call a lot of parents call it a hump period. They had to go through, because you're giving a drug, the body has to get used to that drug being in it. A lot of parents dropped out with their kids because the side effects are so bad. But if they got through that first month, as I call it, from a month to 6 weeks, all of the side effects went away as the body got used to the drug being in the system. And the ones that stayed on it were reporting some beneficial. Now, none of the trials have actually been concluded, so I don't know whether it's been effective in practice. But there was this hump period. Everybody that's thinking about lovastatin and going on a trial with it and decides to run one, or everybody else will say that. Be aware that there is a hump period. They reported at least in the Fragile X.
They do have side effects, but they're generally pretty well tolerated. And compared to, say, some of the anti-epileptic drugs, they're better tolerated than that. I think the reason I would say not to do it is that we don't know that it works. Now you might think, well, we just try it and we see if it works. You know,
Just the thing, if it's a low side effect, what have you got to do?
Yeah.
So you have a child that's
yes.
struggling.
No, I absolutely, you know, I get that and I would understand that. I worry a bit about, it's gone off, I think. I mean, part of my issue with these two kind of case reports is that if you give someone, if I was to come and to say, I've got this drug, lovastatin, and I give it to your child, you will report to me that it works in more chances than not. That doesn't mean that it works. It just means that we all want it to work. And maybe to some extent, it's not just placebo, it's not just that idea that we want it to work, so we're all reporting it works, but also maybe because you're on it, it can give you a little bit more confidence, or someone maybe tries to do something, so you desensitize a bit to things, a bit the way that Rue was talking, so you know, placebos are kind of useful in that sense.
But the placebo effect wouldn't really apply to a lot of our kids.
Yeah.
So when I say placebo effect, I don't mean that the child is thinking it's going to work, or that you're thinking it's going to work. There's something about it's the non-specific effects of taking something that make you. So people came to us to do some of the Fragile X trials. They got better. These drugs didn't work, but their parents reported improvements and they were doing more. But then they were coming to see us. They were traveling more. They were pushing themselves out. They felt a bit more confident pushing themselves out. So there are. I'm not saying that things can improve. It's just we don't know whether or not that's anything to do with the medicine, and you get quite marked improvements without it. Now, I'm not going to stand here and say, don't go. Well, I will actually stand. Don't go buying lovastatin off the internet. I am going to say that. I think from a medical legal perspective, I have to say that. But I think I can understand why you would. And I can understand why families do look towards doing these sort of things. And I'd be a liar if I said I didn't. But I think we need to know whether or not it's going to be effective. Because actually what we want to do is get to the point where it can either be prescribed or not prescribed. We don't risk giving people medicines that have some side effects and some toxic effects when actually we don't know if they work.
I read that statins can cause a bit of pain though. Is that
Cause
right?
muscle pain, yeah, there is. That's one of these commonly reported things in older people. They do have side effects, and they probably have more side effects than we initially thought they would. So, muscle pain and things is one of the potential ones that is being increasingly talked about. No drug is side effect free.
No.
So, they can also cause, lovastatin probably affects the brain. You do get side effects that can be neurological in nature too. So they're not risk-free. The vast majority of people tolerate them pretty well, though it has to be said. We don't know if that's the case in a 3-year-old though. We know that that's the case for people with high cholesterol who are 45, 50. 3, normal cholesterol, there are different issues to work on.
When you talk about the studies, are you talking about the lovastatin being used for seizures and epilepsy specifically, or is there also in studies used to look at other behavioural issues?
So there are no in SYNGAP there are no human studies. There are these 2 case reports. One of them looked at lovastatin for behaviour, which is autistic behaviour and general aberrant behaviour, difficult behaviours. That person didn't have seizures. So they were 30-something years old, they had no seizures. So they were atypical, certainly in the first place. The second study looked at rosuvastatin, and it looked at seizures or epileptic activity using an EEG, and didn't show that great. I don't think it's that great effect. It's there, and it might be indicative of something. And the authors of these things aren't making any massive claims. They're putting it out there and saying, this is kind of interesting, but you need studies to work out whether these things work. My question about rosuvastatin is that there's no animal work being done in it that I know of, and we don't know for sure that it gets into the brain as well as lovastatin or simvastatin do. And we've shown in Fragile X, that even though we know that simvastatin gets into the brain, Emily has shown in Edinburgh, that simvastatin, it doesn't have the effects that we want. So, like I say, my view would be that we should look at lovastatin for a trial, if we're going to do one. But we need a study. This partly relates to your question about why not just try it. This is from the Fragile X trials, different condition, not from LOVA, this is a different medicine altogether. But everyone in these trials, for the first 4 weeks, was on placebo. Okay? So they were all just getting placebo. This is the ABC. Some of them were dropping 20 points on the ABC. That's the same kind of level of drop that you see in that lovastatin study, single case study. None of them were getting active medicine here. So there is a big placebo effect in these conditions, and there's a big, part of the big effort, we're involved in various autism trials as well, is about trying to reduce that placebo effect as much as we can. That's kind of why we need trials, because without it we won't know if medicines actually work. That's the thing. So it's something that we are very aware of, and I think it has to temper the enthusiasm for, those 2 case studies look great. If I was a parent seeing those, I'd be thinking, great. but we need to be cautious about interpreting them. Are we going to do a lovastatin trial? We're planning one. I put up that picture of me when I was younger. This is before I had kids. And I had distinctly browner hair around my temples in those days. So there's another person who's involved in SIDB here in Edinburgh called Richard Chin. He's a pediatric neurologist who's involved in the Muir Maxwell Centre. Richard and I are currently planning our lovastatin trial with some caveats, in that we need to know some more before we decide whether it's definitely worth doing. And part of what we need to know more is about the stuff that's going on in the lab. You know, what is going on with the rat? Does it work for these other phenotypes? Does it show changes in the epilepsy? Does it show changes in the behavior? So, you know, we are planning it, and we're starting to think about how we might run it if we were to, but we have made no definite kind of decision about it as yet.
So what are your timescales on that?
Well, when's Peter going to come up with the rat model?
He always blames me.
Yeah. There's a few things. So, I stood at the SYNGAP meeting, you'll probably remember this, I stood at the SYNGAP meeting, and Mick will remember this, in Houston 2.5 years ago, and said, next year, I'm going to be running a study in SYNGAP1, not with LOVA, but going out, seeing your kids, doing behavioural measures, doing EEGs, doing all that. We're starting that tomorrow, okay? So there's a timeline there. I don't want to give you times. The things that we need, I mean, really, I want to see some more of the rat data. Then we need to get funding, which is a big deal for running trials. For a clinical trial. And then we need to get the approvals. And the approvals is another big deal. The autism trial we're involved in at the moment, it's taken a year to get the approvals. It'll be an even bigger deal if we're looking for approval to do a study in young children with lovastatin, because the safety data isn't as clear for 3-year-olds as it is, and it's licensed for down to 10-year-olds in the US, LOVA, but 10-year-olds with high cholesterol. 4-year-olds, 5-year-olds without high cholesterol. Now there's some data in the Fragile X studies and slightly older kids that we can use, but you know, there are, as well as the scientific things, there's very pragmatic things that we need to work out as well. So, I'm not going to give you a date. I think, you know, realistically, you're not talking any time in the next year. You know, we are also talking. Monica and Bridget Gab are putting us in touch with folks in Germany and in the States who are also thinking about lovastatin trials and whether we try and run something together, whether we try and run separate but comparable sort of things. You know, but this is high on our list of things that we want to do if we think it might be helpful. So I've totally not answered your question.
So how long does a trial typically go on for? So like, do you have to monitor for a couple of years? Are we looking sort of realistically 3 years down the line?
So in terms of actually running the study before we would have an answer,
yeah.
Do you mean? I'll come on to that, because that's a very good question, which is one of those things that we need to work out, really. Yeah?
I was asked by my neurologist to ask about 3 drugs. This is all please let me know, but I have it is related to what you're saying. So there are 5 compa, Riviac, and
Epidiolex.
Yeah, my question is, you know, I've asked that question now, but I think they're all AEDs, are they for
Epidiolex is a cannabinoid based drug. Again, there's some interest.
So how do those drugs link? Is that a different strand of?
It's certainly Epidiolex probably is. Epidiolex is a drug which is licensed now for use in Dravet syndrome, I think, in the UK. Richard Chin was involved in those studies. He has good links with that, the company that runs them. Again, we've had a little bit of discussion. Jimmy Holder in the US, I think, is going to lead on that side of things over there. So it's also on our radar. It's a pharma-sponsored thing, so funding might be easier, but we have to convince them that they want to fund it. And you know, so yeah, we are looking at that as well. But it probably has a different mechanism. But if I'm honest, I don't 100%. It's not a drug that I work with adults with learning disability. Richard's done the trials, he's much more experienced with it.
But sorry, they're different strands. You're working with this drug potentially as a trial, those other drugs are, other people are working on them? Or?
Yeah, well, Epidiolex we would be interested in as well. What you couldn't do is do trials of both at the same time, you know, or you could have some people in one the other, but combining the two in an initial trial wouldn't be possible, or you know. And we're even further. I don't know of the animal research using Epidiolex and SYNGAP. You know, the preclinical research I don't think has even been done. Cannabinoids are something everybody's very interested in, and indeed I know that you've got a child with good effects on them, but...
She used to have absent seizures, and we went to Dr. Alan Frankel, UCLA, first day on 20 milligrams of CBD and 5 of THC, 3 times a day. It was 0.3 ml the first day they went in, and today she has nothing.
So, you know,
so far, Dr. Barbara Stewart's supposed to make an EEG appointment.
So you know there are potentials. We need more experience. There's not. The other thing, I mean, I would caution. I always feel
every person's different, and the doctor will say that as well. And yes, 30 different oils, and every person with SYNGAP1 or Dravet or Rett syndrome, they each have a certain formula for them. It took me 3 different bottles to find her formula, and it's not something you buy online. You get it through the UCLA labs.
And the thing is, there's not enough people diagnosed with SYNGAP1 to tell them who's going to respond to what, who's not, why that is, and things. This is all going to come.
It's been a year she's been off the oil.
No.
I took her off of it because we went to a doctor that works at Oxford in London. She was at UCLA during her developmental appointment, and she mentioned that yes, the oil did help with the aggression and helped with the seizures, but she was decreasing, her appetite was starting to decrease, and she was becoming a bit more agitated, and she recommended me to wean her off the oil to see how she's improved, and it's been a year she hasn't had a seizure.
So these are other things that we need to know, again, that Peter intimated towards, how much, whether or not you can start these things and then stop them again, you know, whether they're going to work, whether they're not, you know, and whether or not people need to be on them their whole life, whether they need to be started at a specific age, whether or not, you know, you can treat in adulthood, or whether they need to be given in very young children. They're all things that we need to know. That's fine. I mean, I would caution against over-experimenting. I think, and I can understand why you might, and I can understand where you come from, and we see this. Medicines can have side effects, and you need to be careful. That's probably all I'm going to say. You know, and so you're doing it. That's with doctor. You know, in the States, this is obviously what they do. That's one thing. Buying internet things, getting involved in, you know, well, we'll try this. I'll say, well, we may as well get some simvastatin or whatever. That's not. I would caution against it.
Yeah, I went to the doctor.
Yeah, no, that's what I'm saying. I mean, I think that's fine, and that's it. And cannabinoids are a really big area people are getting more and more interested in. Like all things, there will be a lot of hype, there'll be cannabis for everything, and then it will settle down, and we'll find what exactly these things are useful for. So, people are looking at various forms of cannabinoids in Rett, we're interested in Fragile X, there will be interest in SYNGAP as well, with these things. So this is all coming down the line. So yeah.
I do want to hijack your presentation.
That's all right. I'm in charge of the timing, so it's fine.
I think it's probably a complete side talk, actually, the use of CBD in SYNGAP. It's probably not in the use of SYNGAP. We use it for epilepsy. I'm not sure it does much for SYNGAP, but it certainly helps in our child's epilepsy in lowering his epileptic NHS, call it medication, raising his CBD level. So I think there might even be a group of people in here that could get together and provide an element of research data that could be circulated to everybody else that they might then decide to pick up or not pick up. But I'm not, from our personal experience, I'm not sure it's a SYNGAP. I don't think it's going to solve a SYNGAP problem, but it might help people with
with epilepsy, yes. And that's what, I mean, that's
And some
what
of the other things
Epidiolex
like
is
sleep.
licensed for. Pardon?
And some of the other things like the sleep.
Yeah, I mean, they can, and anti-epileptics and other ones can also help with mood and things like that. So, so there are off-target effects as well. So yeah, these studies will kind of come online, I think. And like I say, Richard's been involved in those trials in Dravet syndrome. If it was moved to look at the epilepsy and SYNGAP using Epidiolex, it's something that we would be interested in doing. But I don't want to give kids medicines that are potentially toxic without good evidence that they might work. That's ultimately what we come down to. Also, we wouldn't be allowed to, in terms of the regulators and so forth. And we don't know, even for lovastatin, which is the most furthest forward, we don't know that it's going to work. We wouldn't be doing a trial, but we don't even have the evidence enough that it is. Yeah.
And this hypothetical trial,
Mm-hmm.
are there likely to be exclusions of age? I mean, there's some of us that have older children who are getting a little bit twitchy about how much time it will take.
Yes. So, you bring me nicely on to my next slide. Who should we give it to? And this is about age. So, like I say, you instinctively think medicines are going to be more effective when they're young. But as Peter showed in Rett syndrome, there is evidence in that giving, that if you can switch the gene back on, which is very different from giving a medicine, that even in adults you can show rescue of at least some parts of it. There's a little bit of work that's being done in SYNGAP, or somewhat that's being published by Gavin Rumbaugh's group, looking at using the same techniques that Peter talked about in Rett syndrome, but looking in SYNGAP mice. The first paper showed it showed a very little effect of turning the gene back on, but this most recent one showed effects in their young adult mice. Okay, so it showed that they did show some evidence of rescue of some of the fear conditioning paradigm, so some of the fear, the anxiety related phenotypes, and some of the epilepsy related ones. So they did show in their young adult mice some rescue of these things. Honestly, at the moment, in this hypothetical trial, as I'll say at the end, I don't think we're in the luxury of saying, oh, we're only going to look at this age group of people. I think we would try in a wide group of people. My concern is more about how young can we go, whereas I feel personally as a clinician I would be more confident about giving medicines to older adolescents and adults, just because we know more about them. So and this is the first of these papers that just came out this year, very recently, but it raises hope that at least in adults there might be partial effects, at least, if not. I don't think we're talking cures in these with lovastatin or anything like that, and I don't think anybody here, I think we would love that idea, but I don't think anyone's expecting that. But you're talking improvements, benefits, changes that are going to be helpful, that are going to improve quality of life, and going to allow people hopefully to pick up some of those skills that Ruth was talking about earlier on. How long do we test it for? It's the question that you asked. Some of the animal studies, they tend to be about 2 weeks of treatment. That doesn't seem very long. But if you equate that up to a human, that's a year, maybe more, So you probably need to have a decent length of trials. I feel like I'm being very negative. The difficulty of that is it's more expensive. So you're asking funders for more, you're looking at going further out before you make any decisions about whether it is working or not. You're asking people to do more. As I'll talk in a bit, there's quite a high burden for being in a trial. Quite big ask on families and kids and things. So longer trials take more effort on everyone's part, really. Yourselves, families, funders, the money, all of that kind of thing. Also, regulators need to be convinced that you need a longer trial. So why not do one for 3 months? I mean, you want to give these, why do you have to go for a longer time? So you need to be able to justify all of these things. I think we need to test long treatment durations in people. I think we need to test shorter treatment durations in animals. That's the other way of doing this, is say, well, how about 1 day, 2 days? How quickly do we see effects on the seizures, on the behavior, that kind of thing? That might give us an idea about, if we see effects after 1 or 2 days and reducing seizures or changing behavior, well, actually, maybe we don't need to do a 3-year study with these medicines. So it's, there are 2 different ways of looking at these things. And what do we measure to show it works? When we did the Fragile X trials, there was a parent who said to me, if it worked, would we not just know? You know, why would you need to think about what measure you're going to use and how you're going to quantify it and what statistics? I mean, we would just know. But in practice, you don't, because you see these placebo kind of improvements, you know? And maybe with hindsight, at the end, you kind of look back and go, yeah, it didn't really do too much. You know, if I think about it, it wasn't any core changes. But actually, knowing that in the middle of a study is really difficult to do. So we need to think about what we're going to do. The most obvious thing is to look at seizures. But it's possible, a bit like some anti-epileptics work on seizures but don't change behavior, it's possible some of these medicines might work on behavior but not on seizures. So, but I think seizures are probably the most obvious, quantifiable, you know, reasonably objective measure that we can use to look at medicine effect. Clinical observations of behavior, those measures, like Dougal said, things like the SRS, the ABC, those kind of things are all measures that we might use, have been used in other trials. Cognitive tests, looking at what actually someone's abilities are. Things like memory or the ability to learn things or social understanding and so forth, maybe those kind of tests. Or brain function, as people say, EEG, MRI, those kind of things where you're actually getting closer to what's going on in the brain itself. What's really important for trials is data like this. So this is the Bridge the Gap registry. I hope most of you are signed up for it or aware of it. If you're not, I'd encourage you to do so. We can't measure we can't decide what's going to improve if we don't know what the course of a condition is like. You know, you need to know how something presents. And SYNGAP is still new enough. You all know how it presents in your child. You can talk to each other. But when you're doing trials, you need to know on a kind of group or population level what kind of things are there that are coming out that we can measure and what's going to show improvement. So signing up to things like this is really important. Understanding that behavioural phenotype, like people said, is really important.
Is the patient registry sign-up details in the packs?
I'm going to, Katie for that, I don't know, or Melanie, I'm not sure. You're going to talk a little bit about the registry after this, and I'm sure if you just Google SYNGAP registry, this is what you'll find. This is one of the top hits. So, this is a study we're doing, starting tomorrow. This is what we call our NeuroGD study, but it's sort of a neurocognition of genetic disorders. SYNGAP is one of the main things that we're looking at. We're looking at SYNGAP first, and then we're going to look at Fragile X syndrome in regard to this. And people in this room are going to be some of the first people to come through it tomorrow. We're going to try and see 10 people over the course of a day. It's going to be an interesting day. We are going to be looking at those measures of behavior, things like the autistic traits, behavior, just more general measures of behavior, things we're going to try and do some cognitive tests. We're going to see what people can do. Part of it is feasibility. What are children, any children, was going to do them? These are my kids, by the way, 2 of them. But the getting children to engage and do these things, we need to judge what can be done, what can't be done. We're going to try and do some eye tracking measures, which is quite a passive test where people will sit and watch what's going on the screen, and we can tell where the eyes are looking. We don't need to attach anything to children for that. So we're sort of hopeful that that might capture people's attention now. And we're going to try and do some EEG, and we'll see how that goes. This is feasibility. It's getting some initial data. It's trying to work out what we can do, what might be useful. Yep.
I'm from Bryce, so there's no way that I'll never going to get here. Are you going to do any of this?
Hopefully, yes. It is much easier if people can come here. If people can't come here, then we would hope to come down. I'm aware Edinburgh is Scotland, we're a bit north for people and stuff. So yeah.
It's just,
I like Brighton, it's nice. Yeah, my wife worked there for a while.
I'm sure if there was a convergence point, the south east, southwest, etc.
Yes. So no, and this is something that again we need to think about for trials as well, because different potentially centres to run things in. You know, so like I say, from our point of view, we get better data if we can do it all in one place. You know, but if we're coming, if we have, you know, if we're going and setting it up in someone's house, it's different. It's probably less quality.
If you could have centres that you've sort of got a bit more of a control.
Could come down to yes. We
or
can,
even Sheffield.
yes. Yeah. Mixed offering is department for that. Yeah, no pressure. No, but yeah, no, absolutely. To look to see if we can, and that is part. Those of you who are involved in the study will know that literally the research permissions for this came through on Thursday. So I'm glad that we can even do it here. But the plan, that, like I said, we're going to start off, we'll do this here, and then we would like to, and the plan would be to go, because I appreciate travelling, strange place, strange people, all of that stuff. It will massively reduce the number of people who can come.
I'm sure universities, I mean, I work at Sussex University, I'm sure universities will.
Yeah, well, we know we have kind of contacts in various places.
Said if you ever do a trial,
yes. Would be involved, yeah.
We've got 5.
No. Cool. No, I mean that's what we need to do, and it is about building that capacity to do it around the country. Because for a clinical trial, particularly, which I'll talk about, it's a lot more than just coming up and spending a few hours doing this stuff. It's repeated measures. It's going up over and over again over a prolonged period of time. So it needs to be feasible and doable for families.
Elaine Hughes, so Elaine uses specialist for kids.
Yes.
I know she's got at least 5 children with SINGAP, so I was thinking, it is that targeting those people as you say, we've got the umbrella.
So looking at big population centres, basically, you know, because if you're doing something in London, I mean, you probably need one in North and South London, because that's what people are like. But you know, you
big area. I mean, I'm just thinking.
No, I mean, I'm joking. Yeah, you would want you need hot spots. You're not going to have. I mean, again, the problem is, for every site that you add, you massively increase the cost, because you have to pay for staffing, you have to pay for the resources, you have to pay. You pay for shipping costs, you have to pay for your blood analysis. It's balances of these things. But yes, we will be looking. I'm part of a broader EU network of sites involved in autism trials and things, and one of our options would be to look through that for particular sites. But also, I'm very open to individuals who are involved with cases who would be interested in doing these things. Yeah. And that is pretty much the next slide, which is how do we get people to take part? Because demands are high. So the trials we ran in say, Fragile X syndrome, 8 visits over 4 months. People were coming to Edinburgh. They involved visits every 2 weeks for the first 3 or 4 visits, and then it involved visits every month. Phone visits in between. There are blood tests, there are cognitive tests, there are questionnaires, there are physical examinations, there are taking tablets, these are not things that come easy to children with developmental conditions, and are a massive ask on families and things as well. So, we need to work out, there's always going to be demand. Some of these things are unavoidable, but we need to work out some of what we can try and do to make these things better. This is work that Sarah at the back has done, looking at barriers to taking part in research studies, how you might increase participation, what can motivate people to take part. It says about to submit this paper because she's going on maternity leave in like 2 days' time. So but this is stuff. This was done in Fragile X syndrome, but it applies across the board. It looks at what we can do to make things easier. I think there's certain things that are unavoidable. There's going to be blood tests. You can't do a study of a new drug without putting blood testing for safety reasons. And that you wouldn't get it past a regulator. But we can maybe look at doing visits elsewhere, doing things remotely, doing stuff at other centres. We can look at giving people, being flexible as much as we can about when people can come, and some flexibility about procedures and things like that. So there are things that we can try and do to make it easier.
Banked, or is it too complicated if you're having blood for something else, and then you get your doctor to get some banked, and then it's sent up, or is that like
so waiting? You need blood. If you're coming to, so if you're having blood done for something else, then from a research point of view, you can get other bloods done, and we can freeze it, and we can do analyses on it and things like that. From an academic point of view, from a clinical trial point of view, you need to have safety bloods done within a few weeks of starting the medicine. Then you need to have them done partway through. If you look at lovastatin, it lowers cholesterol, you need cholesterol checks. You might be able to do some of these things through finger pricks rather than full-on blood tests, which is practically a bit easier. Yeah, but probably not all of them. You know, that's the thing. You know, so these are all things that, you know, that we're doing more of in trials and things like that, but that we're trying to make them as feasible as possible. And it depends what a regulator will accept. That's the other thing, because the drug regulator needs to say that is a safe study to do. And if they're not happy, then we're not going anywhere. So the other thing to design good trials is to work with families and organisations that represent families and people to find out what are the things, a bit like the work Sarah did, but directly as we're planning trials. So they have a patient and public involvement, they now call it, but basically it's saying, we want to do a study. What do you guys think of this? Will it work? Will it work to get people coming? What's going to make it easy? This is the information we're giving. Is that enough? Do you need more? That sort of thing. So trying to actually engage with families to make it happen. So this is where we're at the moment. We might, and I emphasize the might, be doing a lovastatin study. We're developing it at the moment, but we need more research. We're going to give it to everyone, we think, that we can, you know, that everyone that, depending, young and old, partly because we don't have the luxury of choosing particular subgroups at the moment. We would test it, we think, for probably at least 6 months and possibly longer. Again, that's data that we still need to think about. We're deciding on what measures we might use. We have an idea. There's some of the measures that we want to look at tomorrow. And then there's the NeuroGD study. And how do we get people to take part? That is an open question. We need, you know, as many people as possible, because you need enough people to take part in the study to make it happen. All of that being said, it may still not work. And I think I'm going to end on a downer, but that's just the way I'm, you know, maybe I should be optimistic and upbeat. It's going to work, but, you know, our experience is that these are going to be difficult conditions to treat. There's going to be trials that don't work. We're going to try and do the best trial that we can to answer the question, but it may not work. And there may need to be a few studies and a few trials and things before that we get somewhere.
Will it be blinded?
Yes. So we're discussing this. I think we would probably do what's called a randomized double-blind placebo-controlled trial, where half people will get the non-active drug and half will get an active drug. We would like to then offer what's called an open-label follow-on study where everyone would get the active drug, and that might be our way of getting longer-term data where everyone's on the medicine. That's a bit less useful scientifically, but it also means everyone gets a chance to do it. Again, though, longer study, more expensive. Need to justify it to the regulators. These are all the sort of tricks and balances that we have to put in. To show something works, you need a blinded placebo-controlled trial. An open-label study will not show you whether something is effective or not, unless it's absolutely stunning the effects, and that's unlikely.
What happens if the trial goes ahead to get regulatory approval? If the lovastatin is clearly working fantastically well, and then the trial comes to an end?
So we would, again, this is stuff Richard and I have been discussing. I think we would be looking towards named patient basis prescriptions off label for drugs. I think is where we would be looking at.
Should be able to maintain it.
That is what we would hope, you know. And what you would hope is if it was fantastic and brilliant and things like that, then these things there would be a license deal. Look to start these become available, but it is complicated exactly how you do that, particularly because lovastatin is not available in the UK. It is possible to prescribe drugs that aren't available in the UK off-label on a named patient basis. It can be done, but we would need to work in agreements with local clinicians, and people need to take responsibility for these things. So it becomes, I would say, complicated in that sense. But yeah.
Just one piece on a bit of stuff on is, just say you take 100 kids with SYNGAP1 and they have seizure activity. And of those 100, they, as many are different combinations of medication at the moment. Some didn't work, some worked, some are working. do you add in lovastatin, or do you take them off their medication?
You would not, an experimental drug, I would not be taking people off medicines that they're on.
So if you don't take them off it, how do you then analyse it? Because you've got one piece over here that's been, you've got 100 patients on different anti-epileptic drugs at the moment, and then you add in this. How do you work all that out that it works then?
So what you do is you at very broad level is you look at lovastatin versus placebo, and you are aware of all those other drugs, but you ignore them in the first instance. That's the first analysis that you do. You then can start to look at modifying effects of other medicines, or you can look at people who are only on certain medicines or not. You know, kind of subgroup analyses, but it gets increasingly smaller and smaller numbers. One of the things that we won't be able to do, and I mean this is just generally at the moment, this is where the field is at, is work out if there are subgroups who do respond or don't respond, or whether it needs to be combined with a certain other medicine or not to actually to work it, to see whether or not it's effective or not. There's just not enough people. You need really big studies to look at that. So the answer is to some extent initially you ignore what everyone else is on. You record it, but you ignore it. You just want it to be stable during the trial, unless someone needs to change it for clinical reasons, in which case, yes, that obviously can. And then you try and take account of it in your kind of secondary analysis of the data, in as much as you can, but it's not always possible, particularly in small numbers.
So the key indicators are going to be the improvements in behaviour and in those tests, or that.
Yes, I mean that is our plan at the moment. Like I said, we're in the middle of kind of working out the protocol. We need to speak to the folks in other countries who are going to be involved in these, in efforts in their countries, and then we need to formalise all of that and get the data that we can collect these various measures, and then they're meaningful for people, and then move forward hopefully. So, this is it is still a bit off in question about time. The other thing, which I've not even touched on at all, but which I hope from the middle session of talks today is obvious, giving a drug in itself may not be enough. It may need to be combined with other interventions, behavioural or educational, those sort of interventions, which then the combination of the two might actually be what's likely to be the most useful thing. In the initial period, I don't think we can. That's where the Fragile X field was going. I don't think we can look at that initially just now, because I don't think there's enough people to do those sort of combination studies and things. But that's, we are at the beginning, and I'm sorry, because I know your children are getting older, and I know that we're at the beginning of this process here. But we know a lot from previous work in Fragile X, we know a lot from other conditions, neurofibromatosis, Rett's, etc. So we should be quicker than we have been for those conditions, but it's still the beginning. I think that's me. Oh, I didn't put my email on there, sorry. Anyone who wants me, I have cards and things like that I can give out, or most of you will have heard from Laura. I'm quite happy. You can find me on the internet, that nice picture from when I was young. I'm quite happy for people to email me. I'm quite happy for people to get in touch with us. If you want to take part, there's things you can put your name on if you want to be contacted about the NeuroGD study, just to find out about it. If you want to come up and just speak to us and meet with us at any point, that's kind of fine as well, really, to be honest.